I will just minimize the screen here and then open the PowerPoint for the maternity peds. Okay.
For the high roof models and then what post project.
You want to do newborn?
So the high roof model.
The what?
We need a study for the maternity test this week.
Which is Thursday.
Yeah.
Okay, I will take care of that too, but not today. But not today. Not today. Maternity peds for this week?
Yeah.
It's not today. I cannot give this today. I'm not ready for that.
Okay.
Today we decided to do wrap of all maternity peds topics, right? We said we will break it down. So the goal is to be ready for the big final, which will be happening on the 22nd. So the goal of this meeting, I don't think we will finish in one session. We will need another session, 2 sessions, but we will have collection of all maternity peds. Plus, I prepared also for you this cheat sheet for maternity peds. What high yield topics? So, yeah, so I'm going to give you this
For the finance.
for the final. Yes? Do you guys hear
Thank you.
me here? The people who's joining, like Elizabeth, Shangwi, Zach,
Hello.
Michaela, hello, Joanna, Lori. Who's SH? SH?
It's probably Sin.
Hey, Sin. Yes. And Carolina, Justin, all of you. Yes, Sin. Yeah. Thank you, Zach. So I will have this. Are you here on campus tomorrow?
No.
Wednesday.
Yeah, Wednesday.
We're here Wednesday.
You're here Wednesday. So I'm going to give you this Wednesday. Whoever is not on campus. What is this, guys? This is high yield topics, maternity peds, to use it to study for maternity peds final. Yes, final. So this is for the final. I'm going to provide it on Wednesdays. Okay, but here you go, guys. Who is here? Pick your copies.
Dr. Manal, is this tutoring session for Pete's maternity, or is it
Yes.
for okay?
It is for maternity peds wrap. Wrap means we will summarize everything you learned in term 5. Because I got this request from you. You said before we didn't get. I don't want to say it again because you said you didn't get anything. So it is wrap of all maternity peds topics, exam based. Exam based means when we talk about pediatrics, I will not just go give every single page in the pediatric. What I'm going to give, I'm going to give the topics which is high yield for either HESI or NCLEX. Yeah, you got. So this is the reason I'm going to reteach maternity. I'm going to reteach peds, but different aspect. I will go with the aspect of exams. What will be in finals, what will be in NCLEX, the high yield ones. Deal? Okay. And would you like me to start with maternity or peds? Maternity.
I like Pete's, but I think they're maternity.
Yeah, maternity.
Maternity first and then peds? Okay, we will go in order then. Okay, so this is for today. And we will do maternity one day, peds another day. Then I know you have a test on Thursday on exam 2. This one I will take care of. I will let you know if I will do it online tomorrow or I will do it on ground Wednesday. Yeah, I will be in class. Okay. So this is for exam 2, which is Thursday. For pharmacology, your favorite, I also have this list for you. It's a list of medications, the high yield meds. I'm going to give it today for you guys. And then I'm going to give it on Wednesday for whoever not here. This list is the most important medications. These are the meds which keeps showing in previous exams. And we will review form online during our regular meeting. Yes, I will not like go with this.
Yeah.
I will expect you to know this, but I will present same medications in a different way using PowerPoint and the way I do. Yeah. So here you go.
Thank you.
Very welcome. And these are your copies, guys. Thank you.
Thank you.
You're welcome.
Uncle,
Yes.
What do you do like tomorrow for the other two? Have you do it tomorrow?
I have not decided yet.
Okay.
Is there either tomorrow or Wednesday? I will reach out via group me. I will let you know. Okay. I wish if you told me, guys, you want it online. Duh. Okay. So let's do the. Let's start. So what are we doing today, guys? It is a rap. We will do rap. We will sing. It's a wrap of all what we should know in maternity peds. Ready?
Yeah.
Okay. And let me share the screen. We will start the maternity. We will revisit each topic in maternity. And let's understand maternity. Let's understand maternity, like labor, antepartum, intrapartum, postpartum. You guys know it, but we just want to focus on the most important parts. First question, how do you like my first slide?
It's cute.
Since it is spring, yeah? Okay. So let's do it, guys, together. Let's do it. So, first thing I want to make sure everyone knows in maternity is Nagel's rule. Nagel's rule is how to detect the expected date of delivery. Yes? If you see a topic you 100% know, tell me skip. So you want me to elaborate or skip on Nagel's rule? Skip.
I'm okay with skipping.
GT-PAD. Thank you. Then, let's talk about teratogens. Teratogens are the medications which cause birth defect, right? So I have the collection of all teratogens you need to be aware of. And I use the mnemonic TERA as 2. TERA as 2. T for thalidomide, which is a medication. Epileptic drugs like phenytoin, like valproic acid, they are teratogens. Retinoid, like vitamin A, which is retin A. It is acne. It is for acne. This is so teratogenic. And if I say one of them is very high yield in questions, I will say retinoid. Retinoid or vitamin A, which is given to treat acne. Do you know what is the brand name or the medication name for this in the market?
Accutane.
Accutane. Accutane. Yes, Accutane is the one which in the market. This medication is oral, the Accutane, and this medication is should be stopped a year before she started to conceive. Like if she's taking a medication and she stops medication, she needs to be free from this medication for the whole year. And what tests need to be done before taking this medication? pregnancy test because she shouldn't be pregnant if she's taking this medication. Also, alcohol, ACE inhibitors for blood pressure, sulfonamides, lithium, warfarin, anticoagulant, oral contraceptives for sure. Okay, so remember these medications, this is teratogens, and they like to ask either HISI or NCLEX. I don't want you to like use this session as, oh, this is for my term 5 exams. This is for yourself to make sure I finish the term 5 knowing maternity, knowing peds. Okay. Then another concept which is very commonly asked is fundal height. Yeah, remember before you check fundal height, what you will ask the female to do?
The bathroom.
Empty the bladder.
Empty the bladder. Empty the bladder. Because if you do this, you started to feel the fundus, that will be very uncomfortable, right? So remember the numbers. At the umbilical area, it is 16 weeks. Yes? At the pubic symphysis, it is 12 weeks. Once she started to get the fundus above the pubic bone, this is 12 weeks. Then 16 at the umbilical area. Then 38 at the pubic symphysis, at the xiphoid process. So 38 at xiphoid process, 38 weeks, okay? Then 40 weeks, where it should go? Lungs? Lower. When it goes lower, why it goes lower? Even though it is more weeks, because yes, what process? What we call the process when the fundus goes down? It is engagement. Which means what engagement means, Raiden? Engagement means the head of the baby
It's going
down inside the pelvis, So that's why the fundal height goes down even the weeks are higher. This is another one. We call it Leopold maneuver. Leopold maneuver. This is used to detect the attitude of the baby, like if he's longitudinal like this or if he's transverse. It also helps to know the presentation. Okay, I said 2 words right now. I said attitude and I said presentation. What is the difference between attitude and the presentation? Attitude, guys, is this. Is when you see the long, like if it is longitudinal diameter attitude like this, and flexing his legs and arms. This is attitude, like flexing his legs and arms. But sometimes he's extending his legs and arms. So what is the ideal attitude? Is it flexion or extension? Flexion. So normally the baby should be in what attitude, guys? Flexion attitude, like legs are flexed, arms are flexed. If extended, this is not correct. Okay. Then we can do the position, the head position. As you see here, they can check the head position. The head is rounded and firm. Rounded and firm. So if they do the pubic, they feel above the pubic bone and it is soft, not firm. What do you expect? If it is rounded and soft, do you think is it head?
No,
It will be the buttocks area. So if in the pubic area they feel rounded, firm mass, this is the head. If in the pubic area they feel rounded, soft, it will be the buttocks presentation, right? It will be a breech presentation. Okay, and the back also, they do another movement to feel where is the back. Look at the back, guys. The back always toward the occiput. The back always toward the occiput. Okay, so I will give you example here. Yes, ready for the example? So you will tell me
Hmm.
what position. Position is either left, LOA, or ROA, right? Left occipital anterior, right occipital anterior, or sometimes it is occipital posterior, right? Okay, so ready guys for the example? And the ones online, ready for the example to hear it?
Yes.
Okay, so the nurse is performing Leopold maneuver on a 38 pregnant female, 38 weeks gestation. Feeling suprapubically, the nurse felt firm rounded mass. On the fundus, there is soft rounded mass. Then the nurse performed a maneuver which put the hands on the sides of the uterus. On the right side, she felt long, firm mass. On the left side, she felt 4 rounded masses. So what presentation?
ROA.
It is
ROA.
LOA or right or ROA.
R.
Which one? Put on the chat.
Let me.
Yes. So the long mass on the right side. The long mass on the right side. Long grounded curve on the right side. So if the long rounded curve on the right side, guys, it means what? The occiput on where? Right or left? Right. Yes? So good job, guys. Who said ROA? It is ROA. It is right occipital anterior because you detect where is the back. If the back is right, so the occiput will be on the right, so it will be ROA. If they said the back is left or the long grounded mass on the left, so the occiput will be on the left, so this will be LOA.
So Dr.
Yes?
Manal, basically the back points to where it is, right? Like if it's pointing to the right, it's ROA, right?
Exactly, because the back is the same side of the occiput. So if the back is right, it will be ROA. Good job, Justin. It's a good hint. If the back is left, it will be LOA because the occiput follow the back. Yes? Okay. Good job, guys. Then I want to present these numbers. These numbers are very important to know. Well, you might get question on what is the week where the heart starts to pump. The heart starts to pump at 8 weeks, but we cannot detect the heart beats by ultrasound before 10 weeks. So, but originally the heart can pump at 8 weeks. Then we can detect heartbeats at 10 weeks. At 12 weeks, gender, it can be detected by ultrasound by 12 weeks. Also remember 10 to 12 weeks, this is a good time to take chorionic villus sampling. If we want to do chorionic villus sampling, that will be 10 to 12 weeks. Yes? 20 weeks is the age of viability, and we can do amniocentesis at 20 weeks. From 16 to 20 weeks, this is amniocentesis. 28 weeks, this is when the eye started to open and the surfactant start to develop. What is surfactant? What is surfactant?
It's a hormone that helps with developing the alveoli.
Exactly. So surfactant is a chemical substance. So the alveoli are like big air sacs like this in the lungs. Yeah? So we need these alveoli to stay open. Right? So the surfactant increase the pressure inside the alveoli, so it will stay open. We need to have surfactant in the lungs so the lung can function properly. Surfactant started to develop at 28 weeks, but surfactant will be fully developed at what weeks? Fully functioning, developed, so there is no problem in the lungs.
Was it 20?
28, they started to develop the surfactant. 28. So what week the surfactant is fully developed? If it starts to develop at 28 weeks,
37.
I will 8. Yes, good job, Braden. It is 37. 37. Yes, that's why we said full term is after 37. It is 38 weeks. Yeah, because before 37, it's preterm, and this is a problem because they don't have enough surfactant to keep their lung functioning the best. Good job, Braden. Yeah? So remember, surfactant start at 28 weeks, but will not be fully developed until the 37 weeks. Now, question. What test we can do to check if the lung is mature? What test we can do to check lung maturity? Yep. Everyone.
Chronic-Villus?
Close. You're close. Amniocentesis. Very good. Remember, Justin, chorionic villus, it was so early. It was at 12 weeks, which is no way lung will be. Yeah, you're like, yeah, I got this. Yeah.
Sorry, mixed it up.
Yes, you got this. Yeah. So, you're close. Yes. Amniocentesis is the test. What test we do for amniocentesis? Like amniocentesis, what we want to check for lung maturity. Guys, I will appreciate your chat. What test to check lung maturity? Good job, Lori. She said LS ratio. It is L/S. LS ratio means lithosin sphingomyelin ratio. So we do LS ratio, which is lithosin sphingomyelin Yes, this ratio has to be more than what? What number, guys? This ratio has to be more than
It should be 2 to 1.
2. Very good. It should be more than 2 to show that the lung is mature. Yes, so LS ratio. Okay, very good. So remember 28, surfactant starts. To check lung maturity, we need amniocentesis to do the LS ratio, which has to be more than 2. Also, 28 weeks, many things happen. We can do RhoGAM. First shot of RhoGAM. What is RhoGAM?
Or RH factor.
For RH incompatibility. Very good. If she what RH the female to give her the RhoGAM? She should be RH what? RH negative. Very good, guys. Very good. RH negative female, we give her RhoGAM. First shot is 28 weeks. So remember that date. And next shot, it will be 72 hours after labor. So it has to be 2 shots. Okay. Then also 28 weeks, we start the glucose tolerance test, because glucose tolerance test, it screens for what disease? Diabetes, mellitus, gestational diabetes. Good job. Okay. What is normal fetal heart rate? 120 to 160. So these numbers are very testable items. Make sure you know these numbers very well. And this is, guys, the amniocentesis. You see the picture here. You see how we have the chorionic villus. Sorry, this is chorionic villus sampling. Yeah, my bad here. So this is chorionic villus sampling. They go from the cervix, from the vag, cervix down, and they take sample from chorionic villi. Chorionic villi it develops into placenta. So when I say chorionic villus, this is a thing which will give you the placenta later on. So they take sample from chorionic villi and it is under ultrasound guidance. It gives idea about some genetic disorders. What weeks again? Chorionic villi, it is safe to be done at 10 to 12 weeks. Very good. If the female comes like more advanced in pregnancy, like if she is 16, 18, 20 weeks, amniocentesis is the alternative of the test for genetic testing. Like if you want to check for Down syndrome, neural tube defect, that will be now amniocentesis because she's more advanced in pregnancy. Amniocentesis, which they put a needle under ultrasound guidance, they take the fluid out, they do genetic testing on it.
Dr. Manal?
It is for Down syndrome and the neural tube defect. Yes, my next question is what they will check on this amniotic fluid. They want to check alpha fetoprotein.
Protein. Dr.
Wo- it-
Manal,
Yes.
just to double check my knowledge, this is the only time where we ask the woman to keep her her bladder full, right? For an amniocentesis.
Actually, amniocentesis, you need the bladder to be empty. You know why?
Mhm.
Because look, if the bladder is full, could
You could
it be
actually
poked?
puncture it.
Could be poked by this needle and punctured easily. If it is full, it will be on the way. So this is the opposite. This is the only time you keep her to empty the bladder, because any ultrasound, we ask him to do what? Have the bladder full.
Got it.
Any
So
ultrasound, any ultrasound, bladder need to be full. Most of ultrasound to be accurate. But this is one of the very few times we ask him to evacuate the bladder. You need the bladder empty, because look at this. What will be punctured before we go to take the fluid from the uterus if the bladder is full? We will poke the bladder because it is before the uterus. If it is full, it will be before the uterus. It will be on right under the skin, because bladder is more anterior than the uterus. So we need the bladder to be empty. So nothing on the way while doing amniocentesis. Make sense? Justin?
Hello? Yes.
Yes. Okay. Then what they check? They check the alpha fetoprotein. In Down syndrome, what will happen to alpha fetoprotein, guys? Put on. Yes, it will be low. In Down syndrome, alpha fetoprotein is decreased, but in neural tube defect, alpha fetoprotein increase. Yes, so remember these. Okay. Yes.
About the
Yes.
Is it 72 hours after labor or delivery?
What is the difference between labor and delivery?
I mean, like when the body starts getting labor.
After delivery.
Okay.
Yeah.
I was a little confused.
Yeah, okay. Not the start of, because labor and
Yeah.
delivery is the same.
Okay.
We can say stages of labor and the stages of delivery. Yeah,
Okay.
yeah. Okay. What else, guys, is important to know in maternity? Know the signs of pregnancy, the presumptive, probable, and positive. Okay. I discussed that with you in class. I cannot, like, that will be actually in your final. Make sure you know this very well. If you want to take a screenshot, take a screenshot. Presumptive signs, I will not repeat for the time seeking, for the time seek. Presumptive, know your presumptive, know your probable. Take a screenshot if you want. Know the signs, like what is Ballottement, what is Gödel, what is Chadwick, what is Heger. They are very testable items. Very testable. When I say testable, it's not only for your final. We're talking about the big exam. You need to be ready also with these. Then the positive signs, which is this, the mnemonic fetus, which is helping to remember what are the positive signs of pregnancy. So again, very high yield, testable signs of pregnancy. Okay. Then what else? Sometimes we need to know if the baby is ready to pass through the stress of labor, right? Is labor stressful? Yes. Imagine the baby will be like having contractions on him. You know how contractions feel? Like if you are in a building and the building is collapsing on you. It's not collapsing one time, it's collapsing many times. Boom, 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 right? Okay. So this is very stressful, right? On the baby. And sometimes the baby is not ready, healthy, ready to pass through this stress, right? So the goal of non-stress test to make sure the baby is ready to pass through stressful event like labor. So what they do, there is non-stress test, and then there is a stress test. The non-stress test, guys, is we will be so normal around the baby. We will just monitor to see if he's doing okay or not. So in non-stress test, what they do, they test they evaluate the response of the baby to uterine contractions. So they have the female, they have the baby move. Yeah, they want to check the baby's heart. If the heart can tolerate, right? If the heart can tolerate. So they want to check the baby heart. So they will stimulate the movement of the baby. They might have some sounds near to the mom. Yeah. So the sound might make the baby start moving. And they want to monitor the heart rate while the baby is moving. While the fetus, I shouldn't say baby, the fetus. Yeah. What do you think? If I ask Raiden right now, Raiden, go walk or run, take a lap and come back, move, what will happen to your heart rate? Increase. So we guys expect the same from the baby, from the newborn. If the newborn movement of this newborn should increase the heart rate, correct? Yes. So this is what we want to check in the non-stress test. We will be like, no stress at all. Just show us your heart rate when you move. And we will look at the movement. Once the movement happens, we look at the heart rate. If the heart rate goes high, like Raiden's heart rate, we're good. We're good. The baby's good. His heart rate working appropriately can tolerate the stress of labor. Yes? If the heart rate doesn't go well, like if I ask Raiden, go, take a lap, and then Raiden came back and his heart rate is very low, like 40. Oh my goodness. So what is going on, Raiden? Right? This is a problem. So same for the newborn, guys. If the heart rate goes slower, like it doesn't accelerate, it decelerates. Yeah, if it decelerates, it's a big red flag. It means his heart is so weak, it might not be able to pass through labor, right? So now we can intervene, do the stress tests. I want to make sure now. Raiden, let me do more investigation, right? I will take Raiden to do maybe stress EKG, right? Right? I will do the same for the baby. I will do stress tests for the baby. Yes? So non-stress test, guys, is so casual, which is the baby's moving, check if the heart rate goes fast. If goes fast means accelerate. Accelerate means the baby is good and reactive. If the heart rate in the non-stress test goes down, it means the baby is not reactive, and we want to make sure we will do another test, which is the stress test. Yes? Okay. Who didn't get the first part? First part is okay. Put thumbs up if okay. Okay, guys. Nobody give me thumbs up. It means they either in the
thumbs up.
bathroom taking the shower, or they are sleeping, or they are cooking for their kids. See, Carolina's like put the window up. She opened her screen and she's like, yeah, I'm here. I'm here. Okay, wake up. Wake up. Thumbs up. Okay. So this is a non-stress, okay? How fast? Like how fast is a heart? Like when we do the non-stress, we look for reactive. We look for acceleration, right? How many extra beats we look for? 15. We need 15. Like if his baseline 120, we need to see 135. Yes? So the acceleration we look for is increase 15 minutes, 15 beats, and this increase stays for 15 seconds. Yes? So his heart rate will go higher, 15 beats higher, and then this 15 beats stay for 15 seconds, like at 135. And this need to happen twice in 20 minutes. We need to see this acceleration twice in 20 minutes. So again, to be reactive, we need at least 2 acceleration, 15 beats per minute extra, and this 15 beat extra, like 135 instead of 120, we need to have it for 20 seconds, and it need to happen twice during 20 minutes period. Okay, so let's check if we got this. We will not check. Now, if the baby is not reactive, like if the heart rate decelerates after movement, the newborn is moving, the heart rate goes down. We need to do the stress test. Now let's see what is going on, why your heart rate went down. Yeah? So we will do stress test. What a stress test is? A stress test means we need to find that the baby do not have deceleration. We need to rule out the deceleration because we found deceleration in the first non-stress test. So stress test, we need to rule out this deceleration. We want to say, oh, that was incident and it is not his usual. So if the stress test is negative for deceleration, negative is normal. Negative is normal because it is negative for deceleration, negative for the bad thing. Because deceleration is good or bad? It's a bad thing. It goes down, right? So we want to rule out the deceleration, which because it's bad. So if it is if the stress test is negative, this is normal. But if the stress test is confirming there is deceleration, it means it is positive for deceleration. This is a bad thing. So if it is positive for deceleration, it is bad. Yes? Okay, how they do the test? They induce contractions, actually. They will put her in fake pain contraction. They will put her in fake contraction. They give oxytocin in very small dose to let her contract a little bit. And they will look at the fetal heart rate. If there is deceleration, is it positive or negative?
Could you repeat that? Sorry, you cut out.
Okay. We starting the contraction stress test, right? The contraction stress test. We induced the contraction. She started to contract. With the contraction, the baby heart rate is decelerating. So is it positive or negative result?
It's positive because it's not good.
It's not good. It is bad, right? So if there is deceleration again with contraction, it's positive result. It is bad, which means they might need C-section because he might not be okay to tolerate labor. Yeah? But if it is negative, like normal, the baby is good, he doesn't have any deceleration, means he's good to tolerate the labor. Yeah? Yes. So this is a stress test and contraction non-stress test and contraction stress test. Contraction stress test has to be done in the hospital because imagine she might give actual birth, right? Okay, but the other one, the non-stress test, could be done in the clinic. Okay, question, guys. Everyone here, test your knowledge. What is the answer? You may send me your answer on the chat. And you guys tell me what is your answer. Chat. It is select all that apply. It is select all, sorry guys, my bad. Select all that apply. Okay. So let's go. It is select all that apply. So let's do true or false. Yeah. First one. Which of the following required a non-stress test to be considered reactive? Reactive means good or bad? Good. Okay. So non-stress test. Number one, to increase in the fetal heart rate of 15 beats per minute. Yes. To
That's good.
decrease. To decrease. We will rule out 2 and 4 because 2 and 4, both of them decrease and this is not good. So number one is yes. Number 3, to increase in the fetal heart rate of 15 seconds. True or false, guys? It is true. Yes. So answer is 1 and 3. The other ones are wrong. Number 5 is not correct because it is moderate variability. It should be mild. Justin, it should be mild variability. We accept mild, not moderate. See, one word is a big deal. Yeah? It is mild, not, you were very close actually. Yes, you're right. Okay, so 2 increases during the 20 minutes. Each increase is 15 seconds and increase in 15 beats. Okay, if the fetal heart rate non-reassuring, what you will do? If the fetal heart rate is not like one of the non-stress test or contraction stress test showing non-reassuring fetal heart rate, it is very bad, like there is deceleration, there's a lot of abnormalities, what you will do? Right away, if it is even 32 weeks, we will do C-section. You need to call a friend. You know who you will call? Call the lion. Before you call your doctor, you need to call the lion. I'm not kidding. You know how? You want to know how? Lion. L-I-O-N. L first, you want to lay the mother on her left side. On the left side to why left side? Increase the oxygenation, increase the venous return, because on the right side, she will compress on the IVC, inferior vena cava. So you want to put her on the left, so no pressure on the IVC, so the return happens. So L for lay her on the right, left side. IV fluid, so the blood volume increase, so more blood going to the baby, right? Oxygen for sure, because he needs help. His heart is not doing well. Give oxygen so the heart will not be struggling to pump oxygen. Notify for sure. Notify your doctor. This is not reassuring. You need the doctor intervention. And if she's on Pitocin, which is oxytocin, stop oxytocin because that could increase the deterioration in the fetal heart condition. Yes? So call the lion pet. This is a mnemonic.
So what is Brody? So on the road to recover, Brody is a road for reposition O for oxygen, A for error, then the doctor,
doctor.
and then D for discontinued oxytocin.
I like call the lion more.
Yeah, so
But good job. Good job. I like it. Stick with the one who you remember. Stick with yours. Don't change it. Don't change it. You're good.
To recover. That's how I
Okay. So you guys labor. I know many of us struggle with the stages of labor. So let's make it simple. You guys, the simplicity is the key. So labor, guys, they are 4 stages. What we want to know, what to focus on, please write down this. This is the high yield parts. What they will ask you. You want to know what is happening in each stage. What is happening? You want to know what is happening. Is it cervical dilation? Is it baby deliver? What is happening? And the nursing intervention is in each stage. How you intervene in each stage. Stage 1, what is your role? Stage 2, what is your role? Stage 3 and stage 4. Also, you need to know signs and symptoms telling you the baby is coming. How do you know that the baby is almost there? Yeah? You need to know the signs of placental separation. Very high yield in questions. Signs of placental separation. What to look at the placenta? What are the 2 faces of the placenta? The dirty Duncan, the shiny Schultz. And nursing intervention in stage 4 is so important. Yeah. So these are the things you want to know. Let's start by number 1. What is happening in each stage? Because the question will be like the nurse understand the stage 1 will end by, or they will give you a description of what is happening and they ask what stage is this, right? They tell you what is happening and at the end, what stage radiant, what stage longo, what stage Benicar. They will ask you. So let's know what is happening in each stage and what is your intervention in each stage. So 3 stages. First stage is what is happening? Cervical dilation. Write that down, guys. Simply, like one word. What is happening in stage 1? Cervical dilation. What cervical dilation? And the effacement, right? How big? How many centimeter dilated? It has to be 10 centimeter. This is full dilation. And how many percent effacement? Effacement should be 100%. So stage 1 ends once we have 10 centimeter dilation and 100% effacement. Stage 1, it has 3 phases. Stage 1, it has 3 phases. The first phase, we call it latent, the word lat. Latent. Second phase is active. Third phase is transitional. Latent, active, transitional. So these are 3 phases in stage 1. What will happen in each phase? Phase 1 is the longest. And the cervix will be from 1 to 3 centimeter. From 1 to 3 centimeter. Phase 2, it is from 4 to 6 centimeter. Phase 3 from 7 to 10 centimeter. Phase 3 cervix is from 7 to 10 centimeter. Yes? Phase 1 is the longest, especially in primary. She might take up to the whole day to have her cervix like 3 centimeter. Contraction will be every 5 minutes or every 30 minutes. It depends. The length of the contraction is not long. It is from 30 seconds to 45 seconds, not even 1 minute. So in the first phase of stage 1, this is the description. And then the nurse may advise the female to stay home, just to stay home until active labor start, or if the water break happen. Because so far water didn't break. Because water break at what centimeter, guys? Send me the number. Water break at what centimeter? What centimeter? Water break at what centimeter? It's not in phase 1. Phase 1, we're still in 3 centimeter. So water break in what? Don't guess. It is 5 centimeter. It should break at 5. So you tell her you come if the contraction started to be stronger or the water break. Okay? She's excited. She's nervous talking about she's not like in severe pain yet. Okay? This is phase 1. So look at her face. Comfortable. Then phase 2, it is 4 to 6 centimeter, and the frequency will be longer. It will be like more often. Contraction will be every 3 to 5 minutes and will be longer. It could be up to 1 minute. And now she needs to be in the hospital. She needs to come to be in the hospital. And if she's leaking water, what test you will do? If she's leaking water, what test, guys? You want to see if the water, it is nitrazine. Yes, nitrazine test. You look for what color to know it is amniotic fluid?
Blue.
Blue color. Yes, very good. Phase, you need to check her vitals also in this stage frequently. Now, the last phase of stage 1. Last phase of stage 1, look at her face. She starts the serious part of the labor. What is the name of the phase 3, guys, in stage 1? Transitional. This is the most painful. She started in the real labor. Contractions will be more often, 2 to 3 minutes. Contraction is long. It could take 60, 90 seconds. Cervix, it reach up to 10. Now she's very, very anxious, and we need to accept negative comments. She will not be like the most beautiful one, like the first phase. She will be nervous, in pain, anxious. Okay. Also in this stage, ask her to don't push, because look at her face. She wanna push. She's in pain, but she should not push. Why she should not push? Why she should not push in transitional phase?
Hair?
It's not.
Ex-
Yeah.
Yeah, because she's not fully dilated. She's not fully dilated yet. She's not 10 centimeter yet. So if she put and the cervix is still not dilated, she might rip the cervix. Plus, she would be very exhausted. So when we need her to push later, when the head is out, we want to push now, she will be exhausted. She doesn't have the energy to push anymore. So that is saving her energy, so she can push when we need her to push. When the baby's coming out in stage 2, we need her to push. But stage 1, at the transitional, she will have the feeling to push. We need to discourage from pushing and let her do what? Panting. You know the panting techniques, breathing techniques, like panting like this. Like this. Give her back rubs, but don't push. Yes? So this is a stage 1. Stage 1, what is the outcome of stage 1, guys? Everyone. Outcome of stage 1 is
She's
full
dilation and effacement.
full dilation and effacement. Stage 1, it has 3 phases. The lat. latent, active, transitional. They are all in stage 1. At the end of stage 1, cervix will be dilated. Yes, membrane should rupture at 5 centimeter. If the membrane rupture before 5 centimeter, what we call this?
If it ruptured, prom.
It is rupture anyway, but if it rupture
Yeah, prom.
before 5, we call it?
Premature rupture of membrane.
Yes, good job, Justin. We call it premature rupture of membrane. Prom. 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 Give me a word, one word. If prom happen, what risk? She is at risk of what?
Infection.
Infection. Infection. And the word for infection here is chorioamnionitis. I will put it on the board. Chorioamnionitis. It's a big word for your upcoming HISI. Chorioamnionitis. It's a big word for the upcoming HISI. I don't have the device here, so I will write it on the chat. Here, this is inflammation, infection in the amniotic sac and in the chorion area. This is deep infection. So chorioamnionitis is risk of prom. Prom, as Justin said, it is premature rupture of membrane. Yes? Okay. Then, phase 2, sorry, stage 2. What happens in stage 2? What is the outcome? The outcome of stage 2 is baby is out. Look at the baby here. He should be out. This is stage 2. So stage 1, full cervical dilation and fish. Stage 2, baby's out. Stage 3, placenta is out. So baby is out in stage 2. She should be pushing in stage 2. We need to coach her on how to push. Yes? Okay. In stage 1, guys, I said the membrane rupture, it should be ruptured with 5 centimeter dilation. Yeah? If the membrane doesn't rupture and she's 6 centimeter dilation, should we induce rupture? Good job, very well. Induce rupture. There is a device like a hook. They insert it, insert it 1 for sure, insert and rupture the membrane. Yes? Okay. Stage 2, guys, this is very severe pain. Same frequency of contraction like a transition. 2 to 3 minutes contraction. Contraction is long from 60 to 90. Same frequency, same duration of contraction. You want to make sure the mom is good, monitor the fetal heart rate. Position the mom in high tower or light up. High tower or light up. What is light up? Like the leg.
Anh sẽ nhớ mong một người là chính em, sẽ nhớ thương thật nhiều điều vấn vương, đôi mắt xưa con đường buồn theo vệt thời gian đã hóa tan theo làn sương. Hai ta có trên đường đời nhìn thấy nhau trong phút giây nghẹn ngào thì anh chẳng thể bước tới chào em như trong giấc mơ ta đừng có nhau.
is a
chào
blessing.
em như trong
Never
giấc mơ
how
ta được có nhau.
See that? Yeah. So we can. Oh, by the way, let me tell you something. I can record this meeting. I can record it, but I cannot. I don't know how to share it. I tried before to share, and you get the link, but it doesn't work at your end. So I have no idea how to make it happen. So what I'm gonna do, I'm gonna record, yeah, and then any of you, if you feel you are a high-tech person, just to come to help you to share this with everyone, yeah, but not today. I will just record, okay? Do I have your permission to record?
Mỗi khi em buồn
Everyone.
hay cứ khóc anh
Yes,
nghe
ma'am.
mà
Yeah?
người
Okay,
anh
so I'm
yêu
gonna record,
từng chẳng yêu đuối thế này đâu.
record, and transcribe.
Có người từng nói
So we
càng
started
yêu
the
lâu
recording.
lại càng đau. Thì đúng hết chỉ khác một điều.
So
Chúng ta chỉ
I
vốn
started the
dĩ
recording,
là bạn
guys, and I
thôi.
took permission from everyone that we are recording this.
Từ đầu
Yes?
vốn
Put
không của
thumbs
nhau.
up if
Người
yes.
đến trước bước về
I'm
sau.
gonna take your
Nhìn
permission
cho
here.
anh đấy đủ
your
tốt
permission.
vẫn biết
Everyone say
em
yes.
không chọn anh đâu.
Yeah? Okay. Good.
Anh nghĩ
Okay,
em phải
so
mỉm
let's
cười
continue.
nhưng sau
Again,
đây
what is
nước mắt
this?
em
We're
lại
doing- We
rơi.
will wrapping
Người kia
term
không
5.
tốt không hiểu cảm
Maternity,
xúc
all
anh
maternity,
xa
high yield concepts.
vậy người đáng
all
thương
needs
là
high yield
anh
concepts.
dùng nước mắt để
And
dỗ
now
dành
we have
là
not
điều duy
recorded from
nhất
the
mà
beginning,
anh
but
sẽ
this
có
is
quyền
when
làm
I
đâu
remember to do this.
sâu kín
Now
tâm
we
từ
are
trong
almost
lòng
done with
anh
the
không
stages
yêu
of
ai
labor.
khác hơn ngoài
And this is stage
em
3,
dù
which
cho
is
quá khứ hay
placental
hiện tại
expulsion.
vẫn
Placenta is coming out.
vậy.
Yes? Signs of placental separation is a big high yield topic. So look at the picture here. What are the signs of placental separation? Look at the umbilical cord, how it is hanging in the placenta. So let's think together. If the placenta is coming out, what will happen to the length of the umbilical cord? Will
Đã
it
luôn
longer
hy
or
vọng
shorter?
người em yêu có tên mình.
Longer. Good
Thật
job with
không
cord.
may
So
vì người ấy
cord
không phải
lengthening.
là
The cord is
ai.
longer. Yes?
Anh còn từng nghĩ
Also,
người em
once
yêu
separation
làm em
starts,
vui.
there will be
Vậy
bleeding.
mà kết
Look at
thúc
this.
bao nhiêu
Gush of
ngày.
blood. There will be
Người
gush
ấy đã
of
làm
blood.
em ra nông
Yes?
nỗi này.
So gush of blood, cord lengthening, and look at the shape
Đầu
of the
vốn
uterus.
không của
The
nhau.
shape is this
Người
coil.
đến
Look at
trước
the
bước về
shape of
sau.
this coil in the
Dù
first picture,
cho
on the
anh
left
đấy đủ
picture
tốt
8,
vẫn
figure
biết
8.
em không chọn anh đâu.
Uterus
Anh
is this
nghĩ
coil,
em
put the
phải
placenta,
mỉm
make it
cười
like
nhưng
this.
sau này nước mắt em lại rơi. Người kia không tốt không
It is
hiểu
blocking.
cảm xúc
So
em
the
xa
fundus, the shape, it changes
vậy người
from
đáng
this
thương
coil
là ai?
shape to
Dùng
blood
nước
shape.
mắt để dỗ dành
Yes.
là điều duy nhất mà anh sẽ có quyền làm đúng không? Sâu kín tâm tư trong lòng anh không yêu ai khác hơn ngoài em.
Once the baby's out, once we see the head out, we start suction right away. We do oral cavity first and then the nose.
Phải bị
How
ướt
to
đẫm trong cơn mơ.
Hold the ball.
Nhìn lại mới biết anh yêu em bằng tấm lòng. Người gặp ô lại là ai vẫn ở đây
So
bên
good job, Justin.
em.
So hold the ball, squeeze first all the way out. Put it in the mouth on
Đáng
each
thương
side.
là ai?
And
Từ
each time
đầu
you do,
vốn không
like
của
repeat
nhau.
and suck.
Đến
Squeeze
trước
again
bước về sau.
and suck again.
Cho anh
Yes,
đấy
so
đủ
repeat
tốt
this
vẫn biết em
every
không
time you
chọn anh
use
đâu.
the ball suction.
Anh nghĩ
in the
em
area you
phải
suck.
mỉm cười nhưng sau này nước mắt em lại
Make
rơi.
sure that the signs of
Người
the
kia không tốt
first
không
that the
hiểu
baby
cảm
wants
xúc
out.
em xa.
What are the signs of
Vậy
the
người đáng thương là
Look at the baby.
ai?
You see my baby?
Nước
How
mắt
old is the
để
baby?
dỗ dành là điều duy nhất mà anh sẽ có
I like the picture
đúng
of all the
không?
eyes,
Dẫu
the
kiến
nose, the
tâm
knees,
từ quá khứ hay hiện tại vẫn
Also,
như vậy.
interpostal
Cho
retraction.
quá khứ
Between the
hay
ribs,
hiện tại
there is
vẫn
retraction. We call it intercostal retraction. Nasal flaring. Yeah. Could be color change. Color change in the skin. What color it changes? We look for cyanosis, but we don't want to see cyanosis. We want to just figure out there is respiratory distress before the color change happen. This is late if color change happen. Yes?
mỉm
Then
cười mỗi lúc
stage
thấy
4,
tiếng
it is
nói
last
em
stage.
ngay bên cạnh.
Remember, you do
Giữa
vital
tiếng
signs
pháo
every
đón mưa đêm thêm
15
lạnh.
minutes.
Hai ta trao nụ hôn êm
Lokia
đềm,
in the first
nhẹ
2
thắp
hours
ánh
for
sao
sure.
lửa lên,
Lokia should
cùng vượt
be
qua
one
những
pad
sóng
per
gió
hour.
khó khăn bao cơ
If
hội.
it is
Cũng
more
đã
than
muốn
one
nói ra
pad per
câu
hour,
yêu
if
trội.
she
Tay trong
saturates
tay cùng
more
nhau
than one
đi
pad
về,
per hour,
nhẹ
this
bước
would
trong
be
tim
considered
nửa
bleeding.
kia. Rồi
Also,
tháng ngày
it
phai
shouldn't
nhạt cho
be
ký
big
ức phôi
clots.
pha. Mình lỡ để
Big
danh
clot
vọng đứng
means it
giữa
is the
chúng
size
ta,
of
cho anh
than
quay lại khoảnh
1
khắc ấy,
centimeter size. If
để
the
anh cô nắm
clot
tay
is
em
more than 1
lại.
centimeter, it's a big clot.
Giờ thì mình đã không còn thương, không còn đau, không còn vì nhau nữa. Cũng đã từng mang nhiều điều mong ước nhưng đành xa rồi. Bỏ quên những dấu yêu bao ngày ở lại đằng sau, ta bước tiếp trên đoạn đường chẳng có nhau. Nỗi đau ấy rồi sẽ thay bằng niềm hạnh phúc của riêng mỗi người. Rồi mình sẽ trưởng thành hơn, kiên cường hơn, không còn như lúc trước. Em sẽ dần quên từng đêm không nữa trên đôi vai này. Ngày em có đến bên ai trong đời, thật tâm vẫn chúc em luôn vui cười. Vì anh yêu em rất nhiều, chỉ là chúng ta chọn rời xa.
What is the weight of empty pill pen? 50 grams. Yes, 50 grams, right? And they are 40, yes, Justin said 550. Because 40 pads, each pill pad is 50, so it's 200. And the weight is 750. So it's 750.
Dù sao hai ta cũng đã dành trọn cho nhau tất cả, từng lời đâm sâu thế đã đủ rồi. Một lần anh không hối tiếc, vì dù gì anh cũng biết sẽ chẳng thể luôn mơ về em mãi. Vậy nên anh thôi có chắc chỉ đứng phía xa này ôm trọn bầu trời đêm, đẹp như mắt em ngày đầu khi em nói câu yêu anh. Giờ thì mình đã không còn thương, không còn đau, không còn vì nhau nữa. Cũng đã từng mang nhiều điều mong ước nhưng đành xa rồi. Bỏ quên những dấu yêu bao ngày ở lại đằng sau, ta bước tiếp trên đoạn đường chẳng có nhau. Nỗi đau ấy rồi sẽ thay bằng niềm hạnh phúc của riêng mỗi người. Rồi mình sẽ trưởng thành hơn, kiên cường hơn, không còn như lúc trước. Em sẽ dần quên từng đêm không nỡ trên đôi vai này. Ngày em có đến bên ai trong đời, thật tâm vẫn chúc em luôn vui cười. Vì anh yêu em rất nhiều, chỉ là chúng ta chọn rời xa. Ngày em có đến bên ai trong đời, thật tâm vẫn chúc em luôn vui cười. Vì anh yêu em rất nhiều, chỉ là chúng ta chọn
This
rời
is
xa.
yellow color. And the first one, it should be within the first. Yes, how long it stays? It is 3 to 4 days. Yeah, 3 to 4 days. And then from 4 days to 20 days is a signosa. And then the alba, it will last for 2 weeks. After labor, we need to look for complications like mastitis, breast abscess, lactation. We want to teach her how to lactate, how to put the newborn on her breast, how to help the newborn to latch on the breast. All these are high yield questions, right? So, number one,
Động
What
lại hơi
reflex
sương
you,
hoa mỹ
the
trong câu
nurse,
ca
need
này
to initially
để một
check
ngày nào kia con
before
tim em lắng
starting
nghe
the first
nhìn thấy
breastfeeding?
em lao đầu dũng khí
Swallowing.
nào
Very good.
để
Swallowing.
giang cánh tay
If I
ôm
ask
lấy vào
before start first feeding, it's a
quá khó để
swallowing. You wanna
chăm lo
see
một
if he
người
can
con gái
swallow or
ấm no
no,
hạnh
if
phúc
the
đến
newborn
khi
can
cuối
swallow or
đời.
no. But if I
Bởi
ask
nghèo
what reflex the
quả
nurse
nhiên
need
là
to
ai
teach
cũng
them
thế thôi,
to
chẳng
help
lại
the
chọn cách nắm
newborn to
tay một
latch
người
on the
mà quên
nipple,
đi hoàn cảnh trước mắt lòng than.
which is
Vì
you
quá
got
ngu
to do
si
this
hay vì
on
em
the
đã
tip
yêu
of the
vội
nipple,
vàng,
so he will
vì
just
cá
go
tương lai
towards
nên là em
his
cha nợ cứu
exactly.
mang.
So
Một
not
nụ
these
hôn
reflexes.
thơ ngây
Either
đôi vai phải chịu
or
nhiều gánh vác,
reflexes are
giờ
fine.
mang thêm đau thương vì bởi kẻ phũ phàng. Người muốn kêu ai trong màn đêm tối tăm ở đây, người muốn tìm gì ở sự này để dịu cái đêm đêm khóc than mình em cứ mừng nước xót cho chồng lòng sao anh quên đi và thôi ngóc cho mẹ buông đi hết trong lòng.
It is common with first time breastfeeding. Make sure you have a new bra, doesn't have very tight bra, and heat compression and warm compression is best for warm compression for castrates. Episiotomy, guys, watch for episiotomy. If the wound is infected, give the antibiotics, hit the bath, give a stool softener if there is episiotomy infection, and that because pain will prevent her from defecation. How many extra calories for the mom if she's breastfeeding? 500. 500. Do you remember how many calories when she was pregnant? Extra calories? 250. During the pregnancy, she can get 250 extra. With lactation, she can get 500 calories extra. Okay, let's answer this question together. 2 hours postpartum, the client changes, 5 saturated pads. What should the nurse do next? Select all then apply. Yes, send me on the chat. We remember, guys, we deal with the select all that apply as true or false. What you want to say? Okay, number 1, true or false? Assess the uterus. You want to assess, yes or no? Why no? It is yes, because you want to see if the uterus is firm, if it is soft, right? You want to do fundal massage? You want to check vitals to make sure she's not dying on you, guys? Yeah? What vitals will happen with a hemorrhage? Blood pressure will go high or low? Okay, think one more time. What is low? What is low? What is high? Yes, high pulse, low blood pressure. Good job. High pulse, low blood pressure. Because she's losing blood. Think about this. She's losing blood. So how the heart will go to compensate blood loss? I'm going to pump faster, right? So high pulse and the blood pressure will go low because she's losing volume. So when we lose the blood volume, the pressure will be also lost. Low blood pressure. Yes? Okay. So we will do 1, 2, 3. What about 4?
Yes.
Why yes?
Produces oxytocin.
That produces oxytocin. Should we encourage her to empty the bladder? Yes or no? Yes, why? Don't say yes or no unless you have a rationale. If you can rationalize it, it is yes, it is the right answer. So can we rationalize empty the bladder? Why? Exactly. Good job. So we should empty the bladder because what is a bladder? Right here, beyond the symphysis pubis, right? And then what is behind the bladder? The uterus. Imagine there are layers here under the skin. Skin is first. Behind the skin, Urinary bladder, behind the bladder, the uterus. So if the bladder is full, that will prevent uterus to involute, go back down to the normal size. We call it involution, which is uterus go back. So I believe it is yes, it is encouraged to empty the bladder. What about reassure the client that is normal? It's not normal because it has to be less than 1 pad per hour. Yes, so all of them correct. All of them correct, except the last one. Good job. Okay, guys, tocometer. How is tocometer going with us? Tocometer, I will spend the time to come do it with you like in your skills lab day, because this is clinical, this is a skills lab. So I will bring actual pictures of tocometer and I'm going to explain it thoroughly this Wednesday, promise. Okay, so I'm going to skip the toco. I will skip it not because it is not important. I will skip it because I need enough time to go over it. Okay, so we finished the normal labor, normal pregnancy. We talked about the pregnancy. We talked about stages of labor, right? Okay. Then complications of pregnancy. The risk, high risk pregnancy. What complications? Let's talk about many things. Look at her. Do you see this lady? Many things. Could be ectopic pregnancy, could be placenta previa, could have abortion, abruptio placenta, gestational diabetes, hyperemesis, many things actually. Look at her eyes. Her eyes are saying many things. Okay, so let's talk. Okay, are you still breathing, guys, behind the screen? I have the people here still breathing. Not really, like one of them got stopped the breathing, but he got resuscitated. So what about you? Breathing? Joanna still breathing. Good. Anybody else is breathing? Yeah? Okay. Let's continue. Let's continue for 30 more minutes. We're almost done. Zach stopped the breathing. Oh, he's breathing. Good. Justin, you're breathing? Are you? Are you breathing? Everyone. Should I call everyone? Okay, guys. Let's talk about this picture. What is happening here? What is happening? Yes, cord prolapse. First step. What is your intervention? Cord prolapse. Huh? You check on the fetal heart, you check on the baby, very good, because you have two lives. You have the mom's life and you have the baby life. So don't ignore the baby when we have maternal problems. So cord prolapse, look at the cord. If it is going down like this, look how it is compressed. Look at this. Look at this. Look at the head, how the head is compressing on the baby's head. Yes? So compression on the head, on the umbilical cord, compressing on the umbilical cord, you're cutting what? You're cutting blood supply, which carry oxygen, nutrient to the baby. So what is your intervention? Is it emergency?
Yeah.
Yeah, so what is your intervention? What you want to do? Benny Carr is saying, change the position. Very good. What position? How to position? There is a better position than left side. Good job, Justin. Trendelenburg position is one. What is Trendelenburg, Justin? This is lay on the back, legs up. Elevate the legs. Yes, this is Trendelenburg. Or there is one more position we can use, guys. What is the second one? Yes, who will win? Who's the winner here? Second position we can use for cord prolapse is knee chest. Knee chest position that could elevate the compression from the cord, right? Never put your hand and put it back, right? Don't push it back, yeah? So this is a cord prolapse. You need to put the client knee chest. Left side also acceptable, or Trendelenburg. Okay. Second complication is, because this is your nursing intervention with cord prolapse. Yes? If nursing intervention didn't help, it will be medical intervention. Okay? Then gestational diabetes. Who will remind me what gestation week we do glucose tolerance test? Who remember from the numbers we reviewed earlier? What week we do glucose tolerance test? Yep.
28.
Good job. Good job. 28 weeks. 28 weeks, guys. We start the glucose tolerance test. There's 1 hour glucose tolerance test. If it is positive, it will be 2 hours and 3 hours glucose tolerance test. Gestational diabetes. Is it type 1, diabetes type 1, or diabetes type 2? Type? Is it type 1 diabetes or type 2 diabetes? Type 2. Right? Type 2. Because, good job, Justin. Good job, everyone here. Type 2, because the hormonal changes in pregnancy make her insulin, make her cells resist insulin action. So she gets type 2. Usually, they give insulin shots during a pregnancy to treat type 2, and that increase her risk of having diabetes later on in her life. Yes? Baby. How the baby or the fetus will be affected by diabetes. What will happen to the fetus? Complication of gestational diabetes on the fetus. Overweight. Good job. What is the word? It is macrosomia. Macrosomia. Soma is the body. So overweight is macrosomia. What about the blood glucose in the newborn? Is it hyper? He will be also having high blood sugar like mom, or hypo? Hypo. The baby will have hypo. Do you guys agree? Hypo or hyper? Hypo. Yes, very good. Hyper for the mom, hypo for the baby. But let's understand why hypo. Imagine during the fetal life. During fetal life, the mom keeps feeding him high sugar. So what the fetus pancreas will produce to overcome this high sugar? What the fetus pancreas will produce to overcome the high sugar coming from the mom? What the fetal pancreas will produce to overcome the high sugar? Yes, good job, Justin. It is insulin. So the fetal pancreas will produce insulin, right? A lot of insulin, because it is too much sugar coming to my small body, right? So the fetal pancreas produce a lot of insulin to overcome that high sugar, right? When the baby's out, no sugar anymore, because he's cut from the mom. So no sugar anymore in his blood, right? But what will happen to the insulin in his blood from his body? Still high. So that will cause what? Hypoglycemia. Yes? So understand it, make it make sense. So you will never feel during the test, oh, baby is hypo. Oh, no, hyper. Hypo, hyper, hypo. And you keep thinking. Understand it, make it make sense. So it will not be a guess. It will be based on, I understand why. Yes?
Thank you. Answer will come here.
Okay. What is normal blood glucose level in the newborn? Yes, 30 to 60 is okay. And then first intervention is to have the baby breastfeed the baby, because the blood sugar could be, it is 30 to 60, Justin, but good job. Intervention is to have the baby to breastfeed. start the breastfeeding right away, so hypoglycemia will not be an issue, and keep checking the baby blood sugar. Okay, a big topic. Please don't leave this topic without knowing this very well. Preeclampsia. Preeclampsia, it's a big complication of pregnancy. When I say preeclampsia, look at the chat. Send me on the chat the triad of preeclampsia. What are the 3 things you see while you're assessing patient with preeclampsia? Send me on the chat. 3 things. Put 1, 2, 3. What are the 3 things the nurse expected to find while assessing patient diagnosed with preeclampsia?
Yep.
Okay, Marissa, good job. Justin, 1. Oh, Justin put the 3. Good job. Okay, good job. So the 3 findings, 3 assessment finding. Number 1, proteinuria. Protein in urine. Proteinuria. Protein in urine. Number 2, edema. Start from the lower limb edema. Number 3, high blood pressure, because preeclampsia is mainly high blood pressure. But not every high blood pressure is preeclampsia. It has to be the 3, the triad, to put the preeclampsia. If she is 24 weeks gestation and she has hypertension, she has lower limb edema, she has proteinuria, what is the diagnosis? Preeclampsia. If she's 24 weeks and she has high blood pressure, but no proteinuria, no lower limb edema, what is that? What is the diagnosis? If she's 24 weeks and she has high blood pressure, but no proteinuria, no lower limb edema, what is the diagnosis? Gestational, good job. Gestational hypertension. Good job, Justin. Gestational hypertension or pregnancy-induced hypertension. PIH. Pregnancy-induced hypertension. She got just high blood pressure from pregnancy. Okay. One more question. If she's 18 weeks old, 18 weeks, not old, 18 weeks gestation, 18 weeks gestation, and she has hypertension, what is the diagnosis? 18 weeks, not 24 weeks, 18 weeks, and she has hypertension. What is the diagnosis? It is not preeclampsia, right? Because there is no lower limb edema, no protein in urine, right? It's not PIH. It's not pregnancy-induced hypertension. Not pregnancy-induced hypertension, because pregnancy-induced is the same like gestational. Good job, Justin. It is chronic hypertension. What chronic hypertension means? She might have it before pregnancy. She might have been having this for enough time before pregnancy, but she incidentally found it during prenatal care. Yes? What is the difference between pregnancy-induced hypertension and the chronic hypertension? Timing. Just one simple thing. Timing. Timing is the 20 weeks is your time frame. Before 20 weeks gestation, she has high blood pressure. This is chronic hypertension. After 20 weeks gestation, she has high blood pressure. This is pregnancy-induced hypertension. Yes? So, as simple as this. Look how many weeks gestation she is. If she's less than 20 weeks, this is chronic hypertension. She might have this before pregnancy. If she's after 20 weeks gestation, this is pregnancy-induced. Yes? But if she has hypertension plus lower limb edema plus proteinuria, what she has? Preeclampsia. Yes? Make sure you know this very well, the difference between preeclampsia pregnancy induced, which is gestational hypertension, and the chronic hypertension. Then, how we treat preeclampsia? What is the treatment? The nurse anticipate what medication will be prescribed to treat preeclampsia. MEG sulfate, magnesium, good job. Magnesium sulfate, very good. Why we give magnesium sulfate? To prevent what from happening? No, not hemorrhage. There is no hemorrhage in this story. Why we give MEG sulfate, magnesium sulfate, with preeclampsia? Let's talk more about preeclampsia. Pre means what? Before. Eclampsia is what? Seizures. Eclampsia means seizure. So pre-eclampsia means before seizures. So be careful. This is before seizure. She might seize, right? So good job, Justin. He said to prevent seizures. So we give MEG sulfate to prevent seizures from happening. It helps with the blood pressure also. We give also beta blocker for the preeclampsia female to help with the blood pressure also. Yes? MEG sulfate is great medication, but MEG sulfate toxicity is a big deal, guys. If you're giving MEG sulfate, you need to monitor certain findings. Put me 2 findings on the chat, 2 findings. What you want to monitor for MEG sulfate toxicity? How you know she will start toxicity? MEG sulfate toxicity. You want to monitor yes. There is no actual safety range for MEG sulfate. Whatever you put here, Justin, this is right for digoxin, for lithium, both digoxin and lithium. So these are correct for digoxin and lithium, but the actual number for MEG sulfate is not testable. So don't worry about the one for MEG sulfate. Just to give me the 2 things you want to monitor. If you give your patient, Raiden, you have your patient, you give her MEG sulfate, what you want to monitor so she will not get the toxicity? DTR, Lori, very good job. DTR, deep tendon reflex, Justin, good job. What will happen? This is the first one. First thing I'm going to check. What will happen to the deep tendon reflex? Let's think back. Let's go back. If she's preeclampsia, you do the tendon reflex like this. Preeclampsia, she will have like, oops, very like positive deep tendon. It is +3. It is so like she will move her reflex. She will move her knee fast. So DTR, it will be absent or weak reflex if there is MEG sulfate toxicity. So good job, Lori. Good job, Justin, on the deep tendon reflex. Deep tendon reflex will be absent or weak DTR, weak deep tendon reflex. Normally it is +2, +3. It will be +1 or absent. It is not blurry vision, Justin. Blurry vision, I will talk about it, but it is not MEG sulfate toxicity. So good job, guys. You did give DTR. I want to monitor one more thing. Not halos. Good job, Joanna. Joanna, you got it. Respiratory rate. Very good. Write it down. You guys, write it down. Respiratory rate and DTR are the 2 big things which tell us there is MEG sulfate toxicity. What will happen to the respiratory rate? It will be increase or decrease? Decrease. So decrease respiratory rate. So if you're monitoring patient on MEG sulfate and she started to have weak DTR, respiratory rate is 11. What I'm going to do? Stop MEG sulfate. Stop the dripping and notify the doctor. This is toxicity. So remember, guys, put notes, make sulfate toxicity. If it happens, if there is suspicion, stop the dripping and notify your provider. Let's talk about blurry vision and the headache. It is not a mixed sulfate toxicity, but good job, Justin. You brought blurry vision, you brought headache. Yes. So let's go back to the same lady. She's the same lady. She's Samantha, same lady who has a preeclampsia. Yeah. So she is laying in her bed and she started to be like blurry vision. And she started to be, I have the worst headache in my life. She has headaches, blurry vision, stomach pain. This is not mixed sulfate, but this indicates what? Indicate good. It is worsening. Her preeclampsia is getting worse. She might seize very soon. Good job. It is eclampsia is coming soon. Wow. She might seize. So what will be the precautions you will do? Because she might seize. How to be ready if she... Number one, put the rails up, pad the rails. Yes, yes. And then what about the light in the room? You need to dim the light, because if she started to have the headache, if she started to have the blurry vision, she might seize, right? So you want to have the environment calm to prevent seizure from happening. For sure, give prescribed medication. Notify your provider. But which one I'm going to do first? Dim the light, give her the medication as prescribed, or notify the provider? Which one I'm going to do first? Ah, good job. Do your nursing scope of practice first. Do your nursing scope of practice, because you can do it. This is your scope. Just do it fast. Dim the light. Put the head of the bed up or down. Up, because if you put it down, that might cause more headache, increase the ICP, right? So put the head down, pat the rails, and give medication if it's prescribed, the stand medication, and the standard medication, and then notify your doctor. Have the suction ready, because she might seize, so have the suction machine ready. Very good. Okay, we're almost done, guys. Let me give you 5 minutes a break, and then we will continue until 6:30. Yeah? So 5 minutes bathroom break, and we'll continue. I'll be back. So let me close the recording, and you guys will be back very soon. Okay, guys, then let's get back to this. Let's get back here. Okay, guys, so let's do it. We're almost done. 15 more minutes and we will be done. We're at preeclampsia, right? This is one of the biggest complications we need to be aware of during a pregnancy, high-risk pregnancy. What is HELP syndrome? If we talk about preeclampsia, if not treated well, it could be progress to something called HELP syndrome. But the spelling of the HELP, it is not the H-E-L-P like the regular word help. The spelling of the HELP here is a little bit different. It is H-E-L-L-P. So HP, like you see it here on the screen, H-E-L-L-P. HELP syndrome. What is that? HELP stands for the H-E-L-L-P, so it's here. H for hemolysis. EL, elevated. What? What is elevated? Liver enzymes. LP is low platelet. So HELP is a syndrome, and the word syndrome means many things happening in the same time. And guys, I don't have my writing device because I'm not expecting to have most of you on the Zoom. I thought you will be most of you here. So I cannot write the HELP syndrome, but H stands for hemolysis, EL, elevated liver enzyme, LP, low platelets. So what do you think? If she started to have HELP syndrome, what could be signs and symptoms? What will be the sign and symptoms? Good job, Justin. Yes. I saw you put these. Sign and symptoms. If she has HELP syndrome, what do you expect to find while assessing female with HELP syndrome? Bad coagulation, very good, because there is low platelet. What is a normal platelet count? What is normal platelet count? We need to know our numbers before our final hissy. Platelet, 100, yes, 100 what? 100,000, 50? 150? Yes? Good job. It was, put one more zero. Put one more zero. It is, Justin, put one more zero on the number. It is 150,000 to 450,000. So low platelets mean less than 150,000, right? So platelets will go down. So patient at risk of what? No. Infection is white blood cell problem. Bleeding. So if she has low platelets, she will be at risk of bleeding, right? It is not infection, guys. Infection is white blood cell problem. Our blood has red blood cell, white blood cell, platelets. Platelets, it's responsible for like coagulation, like it prevents bleeding. If it is low, bleeding will happen. If it is high, blood clots will happen. White blood cells, it is part of the immunity. So if there is low white blood cell, this is infection, right? Red blood cell is the anemia. If it is low red blood cell, this is mostly iron deficiency anemia. We'll talk about CBC later, but here low platelets, it cause risk of bleeding. So she will be at risk of bleeding. Elevated liver enzymes will happen in the labs, right? Okay. So this is HELP syndrome. And next is amniotic fluid embolism. Yeah. So the ideal scenario, she is giving birth. She is after stage 4 in postpartum care. She started to have chest pain, shortness of breath. What the nurse should expect: chest pain, sudden chest pain, sudden shortness of breath. What that tells you: postpartum. Something happening with what organ? If she has a chest pain and shortness of breath, what organ you think of? Huh? What organ? Chest pain, lungs, right? Because shortness of breath is lungs. So, what could that be? Good job, Justin. Pulmonary embolism, PE. Could be pulmonary embolism a complication of pregnancy, labor? Yes, sometimes amniotic fluid like bubbles, a bubble escape to the blood, and that will stop at the lung. It will block certain parts in the lung, which cause pulmonary embolism. How to position the female until help arrives? If you doubt that there might be pulmonary embolism, how to position her? What is the best position? Actually, it's a different position. It is unique for the pulmonary embolism because you want to entrap this amniotic fluid bubble from going anywhere. So the best position is, I'm waiting for people. Not standing. Yes, people. Recumbent, yes, right recumbent, left recumbent, what? It is left lateral and the legs up, like it is Trendelenburg, so the legs up, but the patient on the left side. So left recumbent and Trendelenburg in the same time. So put Trendelenburg, the legs of the bed, the feet of the bed is up, and then the patient itself on the left side. So left recumbent with Trendelenburg. That will cause the entrapment of the embolism. It will stay in the lung. It will not go to the circulation. It will not maybe cause heart attack or stroke. It will not travel until help arrives. Yes? So amniotic fluid embolism. Very good job, guys. For sure, apply oxygen. Yes, apply oxygen because lung issues. Okay. Then placenta problem, guys. Placenta previa and placental abruption. It is still, this is also complication of pregnancy. We're still in the complication, high risk pregnancy. So placenta previa. Placenta previa, look at this picture. The placenta is close to the cervix. Normally, placenta should be where? Up or down? Oh, you don't see the picture? Okay. So normally, the placenta should be, why it doesn't connect? Okay, guys, this is a sign we need to stop. The computer got tired here. Yeah, so what left for us is placental abnormality. It is very, we're almost done. So placental abnormality is what left for us. Infection during the pregnancy, we will talk about it, and twin, like multiple pregnancy. So these are the 3 topics we will catch up on when I see you next time. But at this point, this is all maternity, guys. This is a maternity we have been learning since we started. If you think about it, have we learned more than that? This is what you learned in each chapter. we collected all from starting of pregnancy happen. We started by what is happening each week, normal gestation, Nagel's rule, GT-PAD, labor, stages of labor, your nursing intervention, and then complication of pregnancy or high-risk pregnancy. So we have the 3 concepts left for us. We will finish them. And next time, I'm not sure when will be next time, we will do pediatrics. I will make sure we will do that before your final HESI, final OB PEDS HESI. Remind me tomorrow, or not tomorrow, Wednesday, I'm going to give you the pharmacology medications, which are high yield for HESIs. But we will go over the pharm exam on Thursday. But I want you to really have this before Thursday. So if any of you can just send them picture of the pharm things. Yeah. So maybe Raiden, he will take care of this because I want you to start studying the medications and learn about each medication before we meet on Thursday. Because one day will never, don't think one day you will learn about the medication and then you go. Today is Monday. You have today, you have Tuesday, you have Wednesday, Thursday. So you have 4 days to review the medications, and Raiden is working on it, sending to you guys. So learn about this medication before we meet on Thursday, and hope maternity wrap up session was helpful. And we will do the same with pediatrics. And that's it. Thank you for being here. Thank you so much for being here, guys. And thank you for the ones online. And we will talk very soon. Take care, guys.
Thank you, thank you, Dr. Manal. It was very helpful.
Dr.
Thank you.
Manal.
You're very welcome, guys. You're very welcome. My pleasure.